Hello, everybody. Thanks for joining us this evening for another session and another seminar. I'll be speaking today about spinal trauma, observations, considerations. So a lot of what I will be speaking about, some of it's supported by evidence and some of it isn't, and it's based on my experience. So it's up for debate, and I would love to have this session as interactive as possible. I know it's difficult on Zoom, but would love to make an effort in getting everybody's input. So these are my conflicts of interest. And when we stabilize an unstable spinal fracture, we have immediate goals in our mind and long-term goals in our mind. So the immediate goals include achieving spinal stability with anatomic or near anatomic alignment. That's number one. Another one is to prevent neurological decline. The third one is to be able to expedite patient mobilization, and that's important. For instance, you get a case of a patient, let's say, with a chance fracture. Most of these patients are intact on presentation, and say you get the patient admitted in the evening on a Friday, and you're embarking on a weekend. I would certainly do the case the next morning, because by Sunday or Monday, that patient has gone either to rehab or home. As opposed to sitting on this patient over the weekend, doing it on Monday morning, we know that the patient's intact and that may be okay, but why delay the patient's care and expose the patient to DVTs and bed ulcers and what have you, and sometimes pneumonia. So that's why you want to expedite patients' mobilization, get them up and about and moving and discharged. The long-term goals that we think about when we stabilize this fracture is we want to provide the patient with the appropriate construct. So we want to do enough to stabilize that unstable fracture that will enable the fracture to heal with maintenance of alignment, avoiding hence post-traumatic kyphosis. The second one, we also don't want to overdo it. We don't want to fuse many more segments that's unnecessarily so. So we want to spare motion segments as much as we could above and below the fracture. And here comes, that's where percutaneous fixation comes into play, where we want to stabilize those fractures percutaneously and fixate them with the thinking that we want to remove the hardware once the fracture heals. So we're maintaining motion above and below the fracture. So let's speak about spinal stability. I think the best people who define spinal stability are Punjabi and White and their clinical biomechanics of the spine, first edition 1978, the second one 1990. They define clinical stability as a stable spine is a spine that's under physiologic loads, free from deformity, neurological deficit, or pain. Okay, so under physiologic load, a stable spine is free from a deficit, pain, and deformity. And I highlighted pain here, and I'll come to it later, because pain under physiologic load is a marker of instability. So say you have a patient who has, BMI 50, 60, with, let's say, 2 contiguous compression fractures. Okay, and then you're put this patient in a brace, like let's say a TLSO brace, and you're mobilizing that patient. And that patient's significantly in pain. You can't discharge that patient from the hospital. Spending 3, 4, 5 days, 1 week, you can't discharge them. Then that patient, I would probably think of stabilizing them maybe percutaneously, and to expedite their discharge disposition. And I've done that. It's not common, but I've done that a few times. So what happens if we miss on an unstable spinal fracture? What would happen? Well, patients may become acutely paraplegic, quadriplegic if the fracture is extremely unstable, right? However, if we're lucky, we may be dealing with deformity down the line, or both, deformity causing neurological deficit. And here are some examples. So for instance, this patient suffered a car accident while he's driving his convertible, started having neck pain. Okay, after the car accident, they went to the ED and they got an apilateral X-ray, and they said, okay, it's negative, and they discharged the patient home. Patient comes to see me, and this many years ago. 4 or 5 weeks later, now with upper extremity weakness, dysesthesias, and then you can see they missed upon an unstable probably flexion distraction injury with maybe a perch facet. So certainly an X-ray is an inadequate study to use to evaluate a fracture. This is another patient who was managed conservatively following a chance fracture. So you can see the car accident and chance fracture. Then the chance fracture healed, but the patient presented 3 months, 4 months, maybe probably 6 months later with severe lower back pain. It's not back pain where the fracture is, it's lower back pain. Why? Because the patient's trying to compensate, hyperlordosing her spine, lower back, lumbar spine, and flattening her thoracic spine. So the pain is not necessarily at the level of the fracture. It's actually most of the time in the lower back because they're loading their facets, they're changing the biomechanics at the bottom, and that's where the pain is. And handling these unstable fractures right away, it's much easier than dealing with this post-traumatic kyphosis, because here you need to break through the fracture with a PSO and then putting it back together. And that's her post-op day 1. Just see the thoracic spine is a little more kyphotic appropriately, less lordosis here, feeling much better even post-op day 1, up and about the TLSO brace. So here are some of my observations over the past, I've been in practice almost 10 years, but I did a residency that's 7 years before that. So that counts because I was interested in spinal fractures for a long, long time. So I think ligamentous integrity is really important in maintaining spinal stability, more so in the upper cervical spine, subaxial spine, than less so thoracic and lumbar. So the impact of ligamentous integrity is definitely more appreciated and weighs into spinal stability more in the upper cervical subaxial spine than caudally in the spine. Here's an example. This is a 25-year-old man, rollover car accident, mild TBI, intubated at the scene, actually was quadriparetic reportedly. And then when the patient came to the ED, was quadriplegic, dense quadriplegia, intubated. Follows commands with his face. So what do we see here? So I want to make this interactive. And so this is a mid-sagittal CT, and this is a parasagittal CT. And what do we see here? Certainly, patient quadriplegic is a very concerning exam.
Yeah, Nader, this is a case. The first thing I want to mention is not the bony and not the anatomy, it's the prevertebral swelling. If you see what is happening between the cervical spine and the, I think it's the patient is ventilated. You see a tube in the trachea, you see a huge amount of soft tissue in front of. This is what I always teach my residents to look at. And so I mentioned this the first place. And I think we can clearly see the injury between the condyle of C0 and C1. This is an occipital cervical subluxation, luxation. And from the basion to the odontoid process, the distance, you can measure everything. And I think it will clearly show a severe craniocervical injury.
Beautiful. So this is fantastic. So absolutely, atlanto-occipital dissociation, occipital-cervical dissociation, atlanto-occipital dislocation, you can name it many different ways. And you can see purely ligamentous injury. Look at the stir signal here, as Dr. Mamagani mentioned. So the prevertebral swelling and damage. You can see here, it's total segmental disruption. There's no compression on the cervical medullary junction. It's a distractive injury. It's stretched. That's why these patients are quadriplegic, sometimes comatose, but most of the time quadriplegic. Some patients don't even make it to the hospital. That's a common cause of death after these high energy traumas. And you can see here front to back, apical ligaments, alar ligament, tectorial membrane, cruciate ligament, atlanto-occipital membrane, all of it that's disrupted. And you can see even between the scan, this and this, how this moved. So I not necessarily get an MR on these patients, to be honest, but this patient had an MR and we were called to evaluate the patient because they didn't see a fracture. So right away, obviously, this is an unstable injury. What would you do? How would you address this?
So Nader, the patient gets a sign on his bed what not to do, and this is traction. No traction is absolutely forbidden. It will make everything worse. The neurology is getting worse by traction. So compression, pressure on the head to have an axial load, and the thing that the patient needs is the craniocervical open stabilization. And I know he's in a good hand when he's in your hands.
Thanks so much, Alex. Appreciate it. Absolutely. So this is an emergency situation. Sometimes these patients have associated traumatic brain injury, but I find rarely they would have something that is real. Usually it's DAI, not necessarily acute subdural hematoma, because most of the energy is dissipated here, unfortunately, in the upper neck area. So
Hey,
these.
Nader, can I ask you a question real fast before you go past the MRI? You just said you don't always. Hi there.
Good to see you, Wendy.
You just said you don't always get the MRI, and just based on the CT, you can obviously tell what's going on. But what if they, with these kind of injuries, you said there's no cord signal. For this one image, we don't see cord signal. What if they did have hemorrhage within the cord or the brainstem, or transection? They probably would not have made it to the hospital, like you said, but you do see cord injury. That doesn't make any difference for the way you proceed. You just try to do your best. And
great question. I mean, the more you know, the better. But it's so unstable. I'm reluctant of having them transported. One way I would do it probably, crown halo vest stabilization, not traction, and then operating on them. But if I see hematoma inside the cord, this would not necessarily sway me from stabilizing them and giving them their best chance of getting better, because you would never know. I've been surprised by, including this patient, how patients, when you address their spinal cord injury quick enough, you give them the best chance of recuperation. So certainly prognostically, it will tell me, okay, if there's a hematoma within the cord, it's definitely much poorer prognosis than a patient with a stretch injury without a hematoma. So I'd use it more.
Sorry, I didn't mean to interrupt.
Yeah, just as a prognosticator. Yeah.
I was just going to say to Alex, to Dr. Mamdani too, I appreciated that he said that about the prevertebral soft tissues, because it seems to me that's the thing that everybody always misses. And that's like the first thing I tell my people look for too. And they often say, oh, if they're intubated, you can't tell, but you can tell. So I'm glad that he said that. Of course, we shouldn't be surprised.
I think this is very important, because when you look, why is these injuries so deadly? Why do so many people die on scene where the accident happens? It's not because of the neurologic, the problem of the breathing center in the brainstem or medulla oblongata. It's an airway problem. And when we have our ATLS, our advanced life trauma support, then we always categorize 5, A, B, C, D, E, and A is airway. And these patients sometimes suffocate because of a problem, swelling, prevertebral hematoma, and these patients die by suffocation. It's really hard. I was in a trauma school in Hanover, and I was on scene as an emergency doctor, driving with a blue signal to the accident scene. And this is really important. Stay to the rules, A, B, C, D, E. And I was glad when I see these patients intubated and ventilated, because then you have got a secure airway. And this is really, really something you have to prevent, that the patient is in your hospital, he's breathing spontaneously, and then he is suffocating because of a problem that can be easily solved by a experienced anesthetist, and they can intubate with fiber optic and everything like this. These patients belong to a big trauma center with lots of experience. Otherwise, the chance of dying is really high.
Can't agree more. So, the stabilizers in the upper cervical spine are the ligaments. Mainly, are talking about the tectorial membrane alar ligaments that span the odontoid to the both sides of the condyles, and then cruciate ligament, and also the capsular ligaments. I don't want to belabor this. So, how to diagnose AOD? There are many different ways. These criteria have different sensitivities, but they're fairly specific. So you have the BDI that Dr. Magani spoke about, more than 12, Bayesian dense interval. Then you have the BAI, Bayesian axis interval, which is more than 12. These are the powers ratio, Bayesian to C2, Bayesian to C1, C1 to opistheon, AB over CD up more than 1. Then it's a dislocation, but this is not super sensitive because it can miss on an upward type 2 OC dissociation, because AB is equal to CD. And then you have the X lines of Lee, put this line from here to here, from here to here. If the dents violate this line, or the C1 violates that line, then that's an OC dissociation. So, however, the most sensitive and specific method is the condyle C1 interval. You just look at the coronal view and you see if it's more than 2 millimeters displayed. And even easier than that is just to scroll to the side and look at the joint itself and see it's dislocated. Okay, so that's how you diagnose it. Always look at the condyle C1 interval, look at it to make sure, because some of these patients are intact on presentation. So that's the OC fusion, and the patient actually had a fantastic recovery, total recovered, but that's a 3-month follow-up. Here's another case. This is a rollover car accident, 25-year-old woman who was intubated at the scene, and she followed commands with good strength in upper and lower extremities. And she had multiple orthopedics injuries, that pelvic fracture that was ultimately reconstructed, a humerus fracture that was reconstructed, but that was her scan when she came in. So this is a mid-sagittal in the middle, and these are 2 parasagittals. And let's focus on this area. And who wants to comment on this? I know the image may not be displaying super clearly, but let's make an effort. So what do we see here? See, Dr. Gibbs, you want to comment? So this is a not necessarily mid-sagittal. The dens is normal, but that's the cut.
So the dens is normal, but
yeah, the dens is normal. Yeah, but that's the
but
cut.
You got some bone between the tip of the odontoid and the
100%, 100%. That's just the cut that I'm like.
Oh, that's just the cut.
Yeah, that's
on the third image. It looks like there's also a defect in the ventral aspect of that condyle. I see something there.
Yeah, this is yes. So
is that real?
This is real. That's a fracture here through the. It's tough to see. So it's
involving the condyle.
Yes. So this is a condylar fracture. Both condyles are fractured through the skull base, through the clivus. So this is a patient who has bilateral occipital condylar fractures. Okay. Her MRI I did not include, but didn't show too much stir signal, just a little bit here in the between C1 and C2. So here's this patient who has this bilateral occipital condylar fractures. What do you guys think? The fracture is stable or unstable? How would you manage this? This is another image here. These are, see, they're cut here. There's a fracture through here, and there's a fracture through here. So both occipital condyles are fractured. Condyle C1 interval is normal. So
did you say you did get an MRI and you didn't see much? Was it an MRI that evaluated the ligaments, or like the transverse ligament?
Yeah, intact. Transverse ligament.
All the ligaments are intact.
Yep.
Wow. Okay.
So I think it's an unstable fracture. Sometimes we see the condyle fractures like an avulsion fracture. It's unilateral, where the ligaments have got their insertion, but bilateral and with this soft tissue swelling again, prevertebral, I would definitely say this is unstable. And when you do nothing, it has got a big chance to risk to deteriorate. I would really try to fixate the head to the spine by an orthosis. I think the bony healing will occur because we have good bone, and the cancerous bone inside of the condyle can heal. As C0, C1 is not dislocated and the joint can be intact, I think it's not necessary to make a OC fusion. You can do it, but it's not mandatory. Maybe you can have an external halo for a couple of months, 3 months, and then the fracture is healed.
Yeah, I totally agree. So this is a little controversial. That's why I wanted to say that's my experience. I want to share it with you, and I'm taking it sometimes to the extreme. So when you know, some of my partners, when they see this, they'll do an OC fusion. There's like, I don't. So what I would do usually, because I have a couple of patients or 3 with bilateral occipital condylar fractures who were managed successfully without an operation. So because the ligaments are intact, it's a purely bony fracture, I'm not scared on putting them in a CTO brace, nice and tight, and then mobilizing them slowly. Okay, she was not up on her feet because she had a pelvic fracture, but up in a wheelchair, and getting an upright film, and then checking pain, and then seeing how the patient's doing. I mean, definitely can't see the anatomy well here, but you know, C1, C2, there's no subluxation. I can see the condyle here. And I've been able to successfully manage to see, that's a 4-month scan. You can see total perfect healing. So she came in walking, no neck pain, full range of motion. So that's my experience with bilateral occipital condylar fracture. I took it a little bit to the extreme. See, and it perfectly has healed with orthosis. That's an X-ray. So let's.
Nader, what about the caudal nerves? What about the hypoglossus? Did the patient have any problems there?
Great question. No issues with her hypoglossal nerve. Definitely that can happen with an occipital condylar fracture, but luckily she had a normal hypoglossal function. So the classification systems on occipital condylar fractures, we have 2, Anderson-Montesano, and then the Thule classification. And the Anderson-Montesano classifies them as type 1, comminution with minimal displacement, type 2, extension to the occipital skull base, like the one that we just saw, and the avulsion fracture, which can be a touch more unstable, not necessarily. I honestly manage all of these with orthosis, maximum halo vest. Thule's classification, you have type 1, which is undisplaced, and type 2A, which is these OC1, 2 joints are intact. These are stable fractures, versus the 2B, which is an unstable OC1, 2 joints. Well, if it's an unstable, then it's an OC dissociation or atlanto-occipital or atlanto-axial dissociation. It doesn't become only a condylar fracture, it becomes more. So, you know, this classification, like this is an OC dissociation or a C1, C2 dissociation. So certainly it's unstable. So these are the 2 currently classification systems that we use. Here's another lady with the same problem. And just want to point out that these patients may have, you know, her brain is full. She was okay though, like at mild DAI, always have most of the time extremity fractures because these are high energy injuries that cause occipital condylar fractures. And that's another patient here. See, occipital condyle on the left side, the right side, they're both fractured, extending to the skull base, to the clivus. And you can see, here's the MR, right? Like a little stir signal here. Look at the joint, nothing there, minimal stir signal. So really this is, it spares because the energy is dissipated in the bone, not in the ligaments. And that's her fracture healed after 3 months of bracing, full range of motion, doing well. So these are N of 2. You can believe that my treatment is okay. You can believe that it's not okay, but that's my experience. So this is the other claim. Most subaxial cervical spine fractures are treated surgically. So when you say, okay, like say you have 100 cervical subaxial spine fractures, most of them are surgical, except for a unilateral non-displaced facet fracture, except for a Clay-Shoveler's fracture, which is a C7 or T1 spinous process fracture, and sometimes a mild wedge compression fracture. These three. All others, most of the time, all others are unstable. So this is a unilateral non-displaced facet fracture. Got an MR, looks okay. It heals with a neck collar. This is a more unstable fracture. That's a burst fracture of C5. See, it's a 3-column injury. It can trick you. Very unstable, and that needs a front back. Distractive flexion injuries of the spine with their garden variety, unilateral to bilateral facet dislocations, they're all surgical, obviously. This is a unilateral jumped facet. The incidence of a spinal cord injury in those fractures is low, but you have a fracture dislocation here, bilateral jumped fracture facets. Spinal cord injury is higher. So see the ligaments. So the disc is usually disrupted, but so you put them in traction, reduce it to an ACDF. Here, put them in traction, try to reduce it, then a front back, you can't, you go back, long segment, and then you have the spondyloptosis. So these distractive injuries are all surgical. Okay, let's speak about this patient. So this is a patient who's 65, fall off a roof, neurologically normal. Mid-sagittal here, these are 2 parasagittals. You can see here it's ankylosed. So what do we see here? Who wants to comment?
Nader, this is the posture. You can see this is a stiff situation. There's absolutely no lordosis. We have a full ankylosis. This is ankylosing spondylitis or Bechterew disease, how we call it here in Europe. And there are no facet joints in the posterior complex, and we see this ossification of the anterior annulus and anterior ligament. And this is, of course, a C fracture. The alignment is not intact. We see a slip. The posterior is completely fractured, and anteriorly too, highly unstable, high risk of neurologic worsening if not treated properly, and high risk of deformity. These patients go into kyphosis. We have a beautiful chin on chest case. Every spine surgeon has a chin of chest case in his career seen, and it's you have to do surgery, and I would do it from posterior always.
Nader, are you going to get an MRI on this one? Because people with ankylosing spondylitis or other ankylosing disorders, especially ankylosing spondylitis, have very high rate of both epidural hemorrhage and additional fractures.
Absolutely.
Wendy, when I would always ask, when do you want to have an MRI? Because when the patient comes in after a fall, 3 hours later, you maybe don't need an MRI. But if the patient is coming to you 2 weeks or 3 weeks later, the MRI gets more interesting for me because of hematoma, secondary hematoma, which is causing problems. So MRI for me always in these patients.
Yeah, and I would even argue, I think if I just understood you correctly, you said you didn't need it as much in the beginning, but I think also like a very good percentage of these have an additional fracture, which are often hard to see on CT because they're so osteoporotic. Again, ankylosing spondylitis, maybe not all the ankylosing disorders, but that would also be helpful. And wouldn't you worry about having an epidural hemorrhage acutely as well, or is it just not going to make a difference? They're usually not that bad.
If you miss these and the patients getting worse in the cervical spine, in the thoracic spine as well, often it's not the dislocation, it's not the kyphosis, it's an epidural hematoma, an ugly hematoma. If you do a laminectomy, you see some mixed tissue like black hematoma, old hematoma, sticky to the dura. I always want an MRI if this fracture is older, just to know what's inside of the spinal canal. You in Bechterew, in ankylosing spondylitis, you are always the risk of underestimating the myelin compression.
Totally agree. Beautiful comments. Now, I certainly get, so patient with ankylosing spondylitis, if someone calls me, I have a patient with ankylosing spondylitis with a fracture, my blood pressure goes from 150 to 250 because they're high stress. Even getting imaging studies on them, like an MR, because they're so kyphotic, and this is so unstable because that's like a fulcrum. You have a big lever arm with their head and the and this segment, and if you want to put them in a scanner, you want to make sure you're bolstering the head so they're not hanging and worsening the hyperextension injury. We had the patient in the scanner becoming paraplegic because, you know, they let the head hang. You got to bolster. You always want to put like bolster here so they're not hyperextending even further while they're getting the scan. So I always accompany the patient, or my residents will accompany the patient when we're going to get the MR scan. And this in hindsight was actually CSF. That's CSF. So okay, so what do you want to say? Okay, posterior open lung segment, right? Alex, that we wanted to do. And
yeah, always posterior in my practice, and long segment, not short.
Like a long bone fracture.
Alex and Nader, this is Mike. I have a quick question for you guys. Is there ever an instance where the fracture is so distracted that you would consider maybe placing a plate before you position them prone, just for safety purposes?
100%. This one is included. So absolutely, yes. So when you're looking at this, look at this. So you have, there's a step off here. So that's not an extension. It's also anterior translation because of the weight of his head. It's translating anteriorly. So I was really concerned when I want to position him prone that this would further translate and fish mouth, and I get a spinal cord injury. I haven't started the case yet. So if they're really kyphotic, my threshold of doing a front back becomes lower, and that's what I did in this case. So I started off, and you can see this patient. See how much bolstering is there behind the head, okay? And that's the ACDF incision. I'm like doing it like as if I'm doing like a pineal tumor, like in a sitting position. So it's almost parallel to the floor. So that's, and see, I crank the bed down, bolster the head. And that's what I did. I stabilized it so that I'll make the positioning for the posterior. So I staged it because I was really worried about this patient because of his posture. Look at this. This is the sternum perpendicular to the spine. That doesn't look fantastic. That looks high risk of, you know, positioning issue. And I said, okay, if I want to put him prone now for the posterior, he's gonna look like this. So, you know, you're gonna position prone. That's the sternum, right? So that's gonna look like this. It's gonna be very difficult for me to operate on him prone. And I don't want to correct the deformity while I'm fixing a fracture. I just want to stabilize the fracture. So I thought of this. I said, how can I make this like this? Is by doing it seated. So I did it sitting, the long segment fusion. And that's how it looks like. The problem is you got to freehand the screws here, obviously, but the anatomy is definitely disrupted. So you need to really ensure that you're putting the hardware in the right place by, and not misplacing those the hardware, because he's ankylosed. The posterior elements may not look as normal as a normal spine is. And that's the ultimate outcome. Now, this patient, obviously, after the first case, after we stabilized him from the front, there was a CSF draining out of his drain, but it tamponaded on its own. I did not really go in and, like, you know, I just drilled a little bit here and then put the graft, and there was CSF even as soon as I exposed. But that was inconsequential. So that's the case. This is another patient now, 66. You remember, this is an unstable spine, obviously stabilized front back or posterior long segment. Both are appropriate. Multiple points of fixation. This is a 66-year-old male, tractor accident resulting in cardiac contusion, flailed chest, rib fractures, BMI 60, neurologically normal. Okay, that's his scan. Okay, that's T4, T5, or T5, T6, I can't remember, but that's kind of touch upper thoracic. So what do we see here?
Yeah, Nader, we see pretty the same from the biomechanics. We have a high amount of diffuse idiopathic skeletal hyperostosis called DISH in obesity in obese patients. I've never had a patient 60. I was a high 50 was my most obese patient, and it's always the same. You're not sure whether it's a completely ankylosed spine, but it is. It is the biomechanics is like a complete ankylosis. I think the patient has got a dish. Sometimes you see on the lateral, on the coronals, the osteophytes, and this is again a high and stable fracture. Maybe the posterior parts are not so severely injured from the bony aspect, but from the capsule of the joint, and so it's a transdiscal and I think a transarticular injury, and the lever arms are very high, so you have to make a long constrict. And this time, I bet you were not going from anterior.
Correct. Beautiful description. So I agree. He has dish for sure. The cuts just don't show the syndesmophytes because unfortunately I can't scroll back and forth, but certainly has this. All this is ankylosed. All this ankylosed is fractured through it. So, so you all agree. Anything to add, Dr. Gibbs?
No, I don't think so. That was a great description. I can't think of anything else here.
Good. So exactly. So you see this is fish mouth open in the front, 3-column injury. You have a distracted facet here. And as you compare to this one or this one. So that's a 3-column injury. There's no doubts about it. It's unstable. And this is more of the same. That's a stir image, super deep. And that's a 3-column injury. There's no hematoma or like epidural hematoma or anything like that. So, okay, we want to stabilize this patient with posterior long segment fixation, or sorry, fusion, okay? Let's do it. So take the patient to the operating room, place him prone. The pulmonary artery, pressures in the lung, more than 50. Can't ventilate. Flip back, adjusted the tube, place him prone again, peer airway pressure, 45-50, can't ventilate. Has also a flailed chest. So I aborted the case. It's like, can't do the case. Brought him back, ICU. Let's try a week later. Brought him back a few days later, 5 to 7 days, can't remember. That's an old case. Positioned him prone, respiratory arrest. Flipped him back, chest compressions. Like they were vigorously compressing the chest. They revived him, resuscitated, breathing, following commands, intact. Thank God. So what's next?
Nader, it's Mike. How are you, man?
How are you doing? Good to see you, Mike.
Hey, I've been making some comments in the background, just undermining your cases here. But this one is real challenging. But what I wanted to ask you is, did you have a pro-axis table for this guy, or were you trying to use a regular Jackson or a Wilson frame?
This is a case did it 10 years ago. No pro-axis.
Yeah, so there was no pro-axis, because that may get you out of trouble here with the gap in the middle and the ability to hold and positioning kyphosis. But aside from that, this is one you could instrument in the lateral position. That's the other thing. And we've had to do that in the past for some spine deformity cases. So different set of problems, but in a big kyphosis where you take them prone and they stretch out their anterior supply to the spinal cord, we've had similar things in deformity. So I suppose lateral instrumentation is an option here, and good with navigation. I've published a series on doing these, not in the lateral position, but on doing MIS versus open. And we had no non-unions doing these MIS. And so, if you had nav and could go lateral, you may be able to get away with not dissecting out all these tissues here.
Beautiful. And I've done that too in ankylosing spondylitis, actually. Thanks for reminding me, Mike. Beautiful option. They're very ankylosed. They can't ventilate. Peak airway pressure is an issue. Lateral percutaneous, beautiful option. I've done that. The only issue sometimes with rod contouring, you got to make sure you're seating that rod so you're not pulling out those screws. You're not gonna, because these are reduction towers, these are reduction screws. So you got to be cognizant, multiple points of fixation. I've done that twice in ankylosing because of that same reason. But this guy arrested, I don't want to like chest compressions. I was like, man, I'm not gonna operate on you. So what I did in this situation, and that's definitely a road less traveled, but I've done that a few times. Recumbency, old school. Keep him in bed. Put an IVC filter, prophylactic Lovenox, TLSO, bed rest for 8 weeks, then advanced 45 degrees for 4 weeks, then 90 degrees for 4 weeks. Then the follow-up was like every 2 weeks and then every 4 weeks with x-rays. It's very painful to do that because you're following the patient really closely and then you're getting x-rays every 2 weeks and making sure everything's okay. And this is the result after recumbency. Healed, perfect, went back to working. So recumbency, I've been using this a few times in patients who have unstable spinal fractures, for instance, in the setting of osteoporosis. I had a patient who's 91, but super sharp, had osteoporosis everywhere. Then she had a fracture through the 3-column injury. There's no way you can put any points of fixation anywhere. Like severe compression fractures above and below the 3-column injury. So what I managed her with recumbency, and she healed, used the walker, but it's a process. It takes 2 to 3 months. So that's a road through less traveled. I wanted to share this case of recumbency in an unstable 3-column injury situation. So this is the MR healing, and you don't see any stair signals anywhere. On to the next one. So this is a patient who I was consulted to see in rehab. So we have a rehab place down next door. I have privileges, so sometimes they call me, hey, I have this patient, had the MVA, Asia A injury, had a fusion, has a neck collar. This was done 4 months ago. Can we remove the neck collar? So, okay, that sounds good. And that's the x-ray. I may have spoke about this case 4 years ago, or 2 years ago on Twitter. So what do you guys think? So this is a patient who has an Asia A injury. Let's say he moves no movement below the triceps. So triceps about like 2 out of 5, and then above that is intact. Below that, sensor motor level at about C7. What do you guys think? So 4 months after the injury, and he had a fracture dislocation, and they just fused it in situ.
So, Nader, when I can go back to your first slide of instability, you said a neurological deterioration is a risk and deformity is a risk, or both. In this patient, we have, I think, a little risk of neurologic deterioration when he's Asia A, or Asia A means it is complete
spinal cord injury. Spinal cord injury. Complete spinal cord injury. Yep.
Complete. Yeah. So can't get worse. And the deformity, I think we can see the luxation, but no kyphosis. Can we have a CAT scan? Can we have a CT?
This is AP. Plus, they have those screws down in the foramina, but that's a CT. This is a CT.
Okay, and it's 4 months. And
4 months.
Okay, at least we see some good screws below and some good screws above, and I say yes, we can remove the collar and look how here the patient is doing.
Okay, this is the MR. So it's not even a decompression. So what would you guys do? This is definitely controversial, but that's I wanted to share this case because I learned from it.
I think he's at very high risk of post-traumatic syringomyelia. I think there's some good literature about leaving a kyphotic segment or leaving significant canal stenosis. I've seen this several times actually with thoracic spinal cord injuries, where the surgeon would fixate the patient in situ just like this. They leave significant kyphosis, stenosis, and then the patient will end up with a cervical syrinx 3, 4, 5, 6 years later. So I think that's what this patient is probably at higher risk.
Beautiful. Persistent stenosis and kyphosis is a setup for worsening neurological deficit due to the syrinx. It can extend actually even to the brainstem. 100%. So that's good indication to fixing it. Any other indication? Unlikely this would heal, right? Like we don't see signs of healing 4 months after the injury, so that's not gonna heal. So
Yeah,
that's
so
another.
Nader, if it doesn't heal, the hardware will fail, won't it?
The hardware may
20 years
fail.
old,
Sure.
certainly.
Yeah, it may fail. Absolutely, it may fail. I mean, you know, but usually
That is
if
right.
it doesn't heal, then and it's a high stress area, if the hardware is not met, yeah, it will loosen up and fail. So okay, we said,
do you think, Nader, that a color has had prevention in the last 4 months of worsening? What is your estimation? What does a color do in a patient with such an injury?
Besides make them uncomfortable.
Not much, you know. I mean, a young guy who has good strong bone, if you have good fixation, adding a color is not gonna add much. To me, I usually put it just so that, you know, just for about 6 weeks, just to make sure that you know, the patient's not super liberal with like therapy. And then when people see a neck color, they stand, you know, like they won't stress unnecessary therapy above the arms, because I, you know, want the fracture to heal. And it just, but it doesn't add too much in a patient with strong bone in terms of biomechanical stability. So let's say we want to help this patient. What would you and how do you want to fix this? Okay.
Yes. So now we sometimes see cases like these on the conferences, and I think if you want to decompress the spinal canal to prevent secondary syringomalia, you have to do this decompression from posterior. As the implants are there, you will not be able to manage from anterior alone, except of resecting both the vertebrae who are here in this obscure position. And you can do it from anterior with a 2-level corpectomy. This would be a decompression of the spinal cord, and then a plate with an implant that is not compressing or doing a cervical stenosis. This is a challenge. Removing the hardware from posterior and trying to make a reposition will fail. I think this is too stiff. You will not be able to make a reposition after 4 months. I'm looking forward to see your solution.
Thank you. Okay, yeah, absolutely. So first of all, we discussed this with the patient, like the goals of surgery, as Dr. Galgano mentioned. It's like prevent syringomyelia down the line, giving him a chance at a better recovery. You never know, you know, if he hasn't had the decompression, if he's going to get better. The chances are not zero. They're low, but they're not zero. And then to prevent hardware failure down the line, because unlike this will heal. So stage 1, I wanted to loosen it up. So I went posteriorly, did a full laminectomy, facetectomy, you know, total inferior superior facetectomy, or laterally. You see the spinal cord, nerve roots, all decompressed, and then repositioned a couple of screws. And I said, okay, we loosened it. Let's just put him in traction, see if we can realign him a little bit better. And that's 4 to 5 pounds of traction. And he's significantly in pain. I could not go up on the traction. I wanted to, but I could not. And it didn't budge. It did not budge. So I was a little stuck there. I said, okay, let's just continue with the plan, because my plan was loosen it up in the back, reduce it, then do a front back, just put a cage and then flip him and then rod and put some bone graft. So what I did, so I took him to surgery, and then in surgery under general anesthesia, muscle relaxation, still wouldn't budge. So I drilled all this first, loosened it up all laterally to the uncinate, starts budging a little bit, not too much. Then then what I did is like I put a plate and I reduced it with the plate better. Then I removed the plate, put the graft, and that's the end product. Not fantastic, but much better. This patient improved neurologically. He gained function in the triceps. He started moving his hands during the hospitalization. So his outcome was good. So he improved neurologically. So I think what I learned from this is never give up on any patient, chronic or acute. If you want to, if it can be done better, try it. Definitely the patient's exposed to some risks, but you ought to give it a shot, Next case. This is a 55-year-old man on aspirin and intoxicated, fell landing on the back of his head. Neurologically intact, had severe neck pain. And these are the images. So it's mid-sagittal, parasagittals here. Anything that stands out as a fracture?
Not obvious on CT. We don't see. We can see the facets in a good alignment. There's no subluxation visible. I think this is a perfect patient for an MRI, as we can see a narrow spinal canal. If we have a look on the mid-sagittal, the ratio of the vertebral body and the spinal canal, I think it's a maybe congenital narrow spinal canal degeneration.
There you go.
An MRI.
So this is a stir. I think this is a stir, and that's a stir, and this is a T1 and then T2. Let's see. When do you want to?
Nader, going back to the CT, were the facets on that left side okay? It just looks like, on the left, whatever the first one is. This side doesn't look like the last side.
Right, that's right. Yeah, it's a little distracted, sure.
Or not distract. I guess down lower. I don't know. Just something about that alignment on that one cut or on that one slice.
No fractures.
No fractures. Right.
No fractures. Zero fractures. This may be a little distracted. And this one too here on the right side. So certainly that's the case. And this is the MRI. The stir signal. So this is the midline. Parasagittals here, right and left.
Yeah, so you have ligamentous injury, but no osseous. Is that right?
Correct.
You have ligamentous, you have some maybe uplifting of the ligament here. I don't think that's an epidural hemorrhage, but uplifting of the ligament at that level, maybe.
That's
underneath it.
This one?
Yeah.
This is, I think they called it an epidural hematoma. Oh. Yeah.
It looks to me like hemorrhage is going under the ligament and uplifting the ligament kind of.
Yeah. Like it might. Yeah, exactly. Yeah, I agree. I think so. Right there. But it's tight.
Which isn't quite as dangerous. Yeah.
Yeah. Which is not quite as dangerous, exactly. But it's a little bit tight. On the axial it looks tight, and this is the same, more the same here. But the patient's intact. So how would you want to manage him? We stop the aspirin, obviously.
Wendy, may I ask you a question? What do you see in the muscle? Is this hemorrhage in the muscle? Is this edema? What do we see here? These hyper intense signals. What do you tell us? What is this?
Well, so some of this, especially in the midline, is going to be ligament edema and ligament injury, not just muscle. Off to the sides, obviously, it is muscular edema. So I would say probably intraspinous and supraspinous ligament injury here. Maybe ligamentum flavum as well. You can see in them, maybe. Hard to say. Can't tell if it's completely contiguous all the way down. But the muscles themselves, though, I don't know, do the muscles matter? I think the ligaments definitely matter. I don't know if the muscles matter. You can tell me that. Because there's a lot of edema. As far as hemorrhage, it's kind of hard to tell just on stir. I think you might have a little bit more areas of hypointensity in there if it was like bigger hematomas, maybe. But I think it could be either. Any kind of fluid signal is what you're seeing. Does that answer your question? Did I? I understand.
Yeah, I think it's very interesting. If you see these patients and you open them up and you find some interesting findings, and it's always, for me, it's the interspinous spaces, for me, it's not so important in the cervical spine because there's mainly nothing. But it's the supraspinal and the nuchal ligaments. This is torn. I think in this situation we can see a ligamentous injury for sure, but not interspinous. It's supraspinous, which is the nuchal ligamentum nucale, the nuchal ligament, and this will be a hematoma for me. This is what I expect because I open up so many of these injuries. In this case, I think the patient doesn't need surgery. I would just observe him, put him in a collar for a pain reason, not for stability, but for a pain reason, and have a look what is going on in the next weeks. It's painful, yes, but I wouldn't do a surgery at the moment.
So you're saying even if there is nuchal ligament or supraspinous injury disruption, you still wouldn't do surgery?
Yeah,
even though that's
because bony and the discs are stable, the bone structures are stable, and the ligamentum nuchale is injured, yes, but I wouldn't go for surgery. I wouldn't know what segments I have to fuse. It is C1, C7. There's no clear index level, but I'm interested in what Mike from Australia, Mike Salvi, would recommend.
Yeah, Alexander, look, and Nader, Wendy, this is a tough one because Nader's saying the patient's intact. When he says intact, does he have any myelopathic signs? Because he may be motor and sensory intact, but, you know, that looks like a potential myelopathic cord to me.
Yeah, it's you know, I agree. I was really concerned. Intact, negative Hoffman's. He didn't have, you know, like we didn't test his gait right away, but because we're like watching it because of the hematoma.
Yeah.
I was thought that it was an epidural here, but I think it's subligamentous, as Wendy said.
Yeah.
But no myelopathic signs or symptoms.
Wow.
Mm-hmm.
Yeah, I mean, I think it's a really diffuse injury, and I'm kind of with Alexander on this in that, you know, if you're going to operate on this, you've probably got to put an occipital plate on and go down to T2, T3, and, you know, try to build an internal brace, which you can probably do with a halo, to be honest. And this may be an indication for me for actually a pinned halo, or a, you know, I'm not against a pinned halo for this. Keep it on for, you know, 3 months and then take him out, let the ligaments gum up, heal up, and keep a close eye on him.
That's a great thought, Mike. But I agree with you and Alexander and Wendy. That was my initial thoughts. Like, you know, the discs are okay. There's a little stir signal in the joints. Certainly, this is more than you would expect from, you know, that's a lot of tissue involvement and muscle involvement into nuchal ligament, supraspinous ligament. So I said, okay, let's put him in a neck collar and mobilize him with therapy. So I put him in a neck collar. Every time he mobilizes therapy, has a lot of neck pain, he needs to lie down. So I said, okay, let's get an x-ray before he's discharged. He's from out of town. He was like about to leave. So, and I like finished clinic and I said, okay, let me just check on this x-ray before he leaves. So I repeated an MR, obviously, just to make sure the hematoma is not expanding. It was unchanged. Looks tight, but it's unchanged. This is the x-ray when he stood up. No, like this is an adult with pure ligamentous injury, no fracture. When do you see subluxation with no fracture in an adult? Rare, but it's not never.
No,
so
it's not ever. This is.
So he was like wearing his, about to leave. I rushed to his room, laid him down in bed, got another x-ray, 3 aligns. So the plan changed from going home to going to the operating room the next day. That's like 10 degrees, so he can eat. That's before. And that's an ACDF. I use titanium cages all the time now, but this one did it a few years ago. I used to use carbon fiber / PEEK. So that's carbon fiber. So see what I'm saying? Like an upright film is super important. You want to mobilize somebody, you know, with a brace, get that upright film, 100%. I do it with all my patients, but I was not expecting that. But it was like every time around him, it's like, okay, now I have a lot of neck pain, but when I lie down, it feels much better. Like, so
Nader, can I ask you? So, I mean, to me, just not having to do this like you all do, it seems like if you have disruption of the supraspinous and interspinous ligaments, why wouldn't that happen? And I also was under the impression those didn't heal as quickly. And so, I mean, healing of ligaments like that are big,
I think what I learned is I agree with you, and I agree with Alex. Like Alex says, I don't care about the interspinous ligaments, but the supraspinous and the ligamentum nuchae, and certainly they're stabilizers if they're disrupted. Add to it, plus maybe a little stir that some involvement in the joint would drive it to instability. Yeah, so I'm paying attention to this, but I don't know, I think, the thing is you can mobilize them and then see, maybe get an upright film and see if they load their spine and see if there's any movement. I think that may be reasonable, but I was honestly surprised to see that. No fracture, pure ligamentous in an adult. So that goes to the first principle, the ligaments. You say muscles too. Maybe that won't happen if someone has, a football player, right? Like the football player, they're definitely more resistant to injuries because of their thick paraspinal muscles. You see them like falling on their heads, hyperextending. They stand up and walk away. You know what I mean? So certainly the integrity, spinal like the integrity of spinal stability is definitely contributed by the muscles around the spine, not only by the ligaments and the bones. So let's see. We have more time. Oh, we're past the hour. I have more cases, but. Thanks for joining.
Nader, just real quick.
Yeah.
I know we're on the hour, Nader, but Matt Burchuk on the chat has just asked anterior alone for this versus AP. It's a posterior injury, and you've gone anterior.
I think so. I think that's fine.
I'm not against what you did, mind you, but I think it's good to talk that out. Just real quick.
I think if bone is healthy, I think an ACDF is sufficient in my experience. Like for instance, I think about it for like a unilateral dislocated facet fracture. I'll put them in traction, reduce it, then I'll go with a single level ACDF. If you go with bicortical purchase on those screws, that's even a better construct. I think it's sufficient. In my opinion, my practice. That's my two. These are my 2 cents. If the bone is strong, the bone is healthy, screws are long. My screws in this particular patient were not, but I'll show you a case. Let me show you this case. So this is a case with a complete spondyloptosis. Okay, patient was had only radiculopathy because the lamina was fractured. And I did it just a single level ACDF. I would never do that, but that's like a long time ago. And that just to show the strength, the bicortical screws, they really improve spinal biomechanics, but you need to make an effort in doing them. I would not do that, but I'm just saying, this is just a case, not advertising that for a 3-column injury doing just a single level ACDF, but you can get away with it. That's a much more unstable fracture than this one, for instance, than this one. So yeah, I think unilateral perch facet, to me, traction ACDF, that's what I do.
Thank you, Nader. This was really, really interesting cases, a great discussion. I just wanted to add one thing for the posterior ligaments in the cervical spine. When we do laminectomy, I come from a time where multi-level laminectomies have been performed in multi-level cervical stenosis, and we all know that adding fusion can be really helpful and is mandatory today. But 20 years ago, we did a lot of laminectomies, and not everybody went into kyphosis. And 2-level, 3-level laminectomy, there's no ligament interspinous anymore. It really is possible. It's not my recommendation, it's possible, but have a look at the joint capsule. You cannot resect the joint capsule at the same time. This is really a big mistake, a surgical mistake. And I guess when we have better MRIs, maybe we could have seen the injury better. Maybe, I don't know, the last case with a secondary subluxation is so important that we all know that this will happen if we don't follow up. And when the patient comes from a rural part, far away, this makes a difference compared to a patient who is living downtown and can see a spine center within two hours. And so it's really nice cases, Nader. Thank you very much.
Thank you so much, everybody. Thanks, Alexander. Thanks, Wendy. Thanks, Mike Selby. Thanks, Mike Algano, for joining, and all of our esteemed audience and enthusiasts of spinal surgery and spinal anatomy and biomechanics, pathology. And who's presenting next week?
So I'm hosting next week, and I will announce on Twitter what's going on next week, and I will inform you on next Monday or Thursday.
Thank you so much, and thank you everybody for joining us. And I wish you good evening, wherever you are. See you guys.